68 years old with a progressive extensional angina since 2 months ago. The past history he has hypertension and dyslipidemia and laboratory with a normal. The ECG
Heparinya udah 10.000.
sinus, yes.
Untuk
With
1,5 jam
imperial wall
tambah langsung.
ischemic and chest-ray myocardiomyopathy and echo show the hypokinetic in posterior imperial wall with ejection fraction of 55% and the cath lab is CTO. The therapy is normal, dual antiplatelet, nitrat, bisoprolol, candarin, and labeprozole. He has a syntax called 256. There is for
Sure.
PCR. Huh?
So let me stop here. As you may have seen here on the screen, the patient has progressive angina and triple CTO. But it seems that all parts of the myocardium are still viable. Only a small part, posterior inferior, is hypokinetic. Ini jangan diperlihatkan dulu, saya nggak suruh diperlihatkan. Tolong kembali ke slides. Lawan. Kalau nggak disuruh itu jangan. Tolong, may I go back to my slides? The very first slide. Don't. Okay. I'm so sorry. So let me continue. So you see here, patient has progressive angina, triple CTO, five muscles, even though part of the in posterior vertebral is hypokinetic, but what is interesting here is that the syntax score is extremely high, 56, but the Euro score and STS score for cabbage are indeed very low. So the patient is in a high risk for PCI and very low risk for cabbage. Dr. Linda will continue with the film. Please proceed with the film. Let me do the advancement of the slides.
In FCA, the protocol from the proximal and from LED and LTS, also the CPO. These have high risk of PCA and low risk for KBase. Right?
Okay, next. Yeah.
Yes. Okay, we are ready. Hi. Yes. Okay, continue.
Next. So allow me to stop here and ask your expert opinion.
Okay.
Because we haven't started with the case.
All right.
You know that you are more expert than us yet. We are waiting before we start.
That's a really tough case, but I would like, all my panel members to give their opinion. Okay, let me first ask Dr. Ila, what would you do if you are, estimated from the past years?
So I'm sure there's a really good reason why we're doing PCI, because it's clearly a very good surgical case looking at the figures. and a very complex
Kalau bapak saya bisa kok tangan dua.
PCI case. The CTO is involved in multi-vessel disease. So I presume that it's either a surgical turn down or more likely the patient doesn't want surgery.
Okay, so habits. Okay, Dr. Crowder?
Yes, sorry. From Santoso, I from Bandung. I think according to my opinion, I think of course it's different with your hands for handle this patient. But according to my opinion, I think because the very high risk for PCI, I think I will suggest to this patient to do the KBS first. This is my opinion.
Dr. Afdal?
Yeah, thank you. After from Batam, from presentation, in my opinion, the first I started for KBH, but we look the syntax score 50, 56. Maybe we can have option for the PCI. Thank you.
Okay, so a lot of us actually suggest for habits, but I think patient preference actually sometimes it depends on the patient preference. But what about your discussion with the patient?
What about your own personal opinion, Dr. Bambang? You are an expert in PCI.
All right, bro. So I think regarding the data, the very high syntax score, we know exactly that the potential risk for doing PCI is quite high, and then habits, the use score, the risk for habits is quite low. So it is fair enough actually to discuss with the patient that the better option is habits. But
Seharusnya kita buat tripod ya, Pak.
sometimes patients prefers as the king.
Gak apa-apa, Pak. Gak apa-apa.
I would
Apa-apa sampai
if the patient
sampai
refuse
kapan sih, Pak?
surgical
Sampai selesai, Pak.
procedure, I would think
Nanti kalau Bapak capek gantian sama saya, Pak.
to do stage PCI, and my first target probably be a lady. That's your opinion, bro.
So I appreciate all the opinions of my respected panelists. We have discussed this with the patient, and the patient prefer to have PCI done instead of cabbage. Of course, in this kind of situation, we have to consider a lot of factors. Among others, risk stratification, as we have done before, presented, syntax score, nerve score, euro score, and so on. We need also to assess the anatomy, the complexity of the anatomy. We need to consider the presence or absence of comorbidity, including kidney function, diabetes, other conditions which may make cabbage more difficult. The availability of in-house good interventionists or in-house good cardiac surgeon, discussion with the heart team, of course. There, among others, there are so many things that we need to consider before we embark on the procedure. If we look at the syntax score, and we follow the guidelines, 2021 American guidelines, this is a good candidate for cabbage, of course. I'm so sorry. Can I speak continuously because I always hear echo?
Oh yes, you
So
can. We can hear you very clearly. Don't
So,
worry. Just go ahead.
I don't need to stop from time to time from one sentence to another sentence.
No,
Because I
just,
always hear echo coming back.
just go ahead. We can see you
So I
very
can speak
clearly.
normally?
Yes, yes, of course. You can
Can I
do it.
speak normally? Okay. Okay. Because this is a safe time. Okay. So if we look at the syntax score, it is very high. But we all know that syntax score is derived many, many years ago. And at that time, they are using Texas, which is the very first generation of STEM. They don't use intravascular imaging, functional assessment, and I don't think that the technology is as good as now, what we have now. If we look at the spline analysis, particularly for Lehman situation, in very complex case, if the syntax score is less than 33, 33 and 32, above 32 is considered as complex case. So below 33, the hazard ratio is in favor for PCI. Only above 45, then the hazard ratio is in favor for cabbage. However, in this patient, the syntax score is 56. So, if we want to do PCI, we have to do that very, not only safety. Safety is the very first thing that we have to adopt. But not only safety, but efficacy also. We need to get complete vascularization. And that's very important in order to get a good short and long-term outcome. We all know that this patient is considered as a complex patient. So the procedure is complex PCI. He has multivessel disease, he has CTO, he has multiple lesions in one vessel, in each vessels. He may need a long overlapping stent implantation of more than 60 mm. And depending on the result of imaging, I anticipate that he may have significant calcifications, which is very common in this kind of anatomy. So, at least very complex anatomy and complex PCI procedure. Again, depending on the definition used, which may differ from publication to publications, this patient may also be included in the CHIP as a CHIP patient. So, as we have decided to do PCI, we want to do that as perfect as possible, but on top of that, as safe as possible, with the best procedure, if possible, and the best stent as possible, to get a very good short and long-term outcome. If we are fortunate enough to be able to fix all these three vessels, the sign of choice, in our opinion, is dynamics. And we will let you know later on why we choose dynamics. So before we go on and present what we have done so far, We would like to have your further opinion. Any more questions?
Oh, okay. So, Prof, to my eye, actually, I couldn't clearly see the flow from the LED. But there is, we still can see the distal, runoff. But I'm not sure whether that is the what you call it, the anti-creep flow from the microchannels or from the collateral. I'm not so sure. Can you just clarify?
I will show you the next slide. So you will get the idea of what we have done so far. This is a staged procedure because, of course, we could not finish all these 3 CTOs today in this very limited period of time. So, just a few days back, we have fixed the light and the LED, and you will also be able to see the film. Okay, Dr. Linda will present the case and what we have done so far. Can you see the slides now?
Yes, we can see. We can see the slide clearly.
Okay. Before Dr. Linda explain, let me tell you something. It is very, very unusual to use OCT in CTO intervention. But in this particular case, I use OCT. If you would like to know why, the reason why, the plus and minus, I will let you know. But Dr. Linda will first explain the OCT findings. After, of course, after crossing the wire, the lesions with the wire, and then do progressive dilatation. Dr. Linda, please.
We stop here is a diffuse disease.
Can you see?
Yep.
Okay. With a fibrolipid plaque and fatty calcification and ballot-induced dissection mainly in proximal RCA.
Any question before we move to another slide?
Is there any very difficulty in crossing the CTO lesion?
If I am assisted by Dr. Linda, everything seems to be easy.
I mean, do you use
Dr. Linda.
what kind of guidewire you use?
Well, as usual, as what you do also in your clinic, we normally use a microcatheter. Any microcatheter will do, and then we use a Volkhaus wire. Advance the Volkhaus wire just close to the CTO, the proximal end of the proximal cap of the CTO. Don't advance. Never advance. Then pull the wire out. Then we will introduce. Usually, we use if we see still a small channel. Our wire of preference is a filter, like filter XE, not filter XE or SER, but just filter XE from Asahi. If it doesn't cross, and we can still see the track. You can use, we normally use Gaia series, Gaia next series, like Gaia 1, 2, 3. But if the track is not very clear, our wire of preference is Gladius 14 or Pilot 150 or 200. So in the case of very long CTO like this, if I correctly recall, I used pilot. I used 14. Also from Asahi. So you can just move and then it will, I must say, go by itself. But what very important is that you should not make the tip, you should make the tip very, very small. That's the wire.
You mean the curve? The tip of the curve of the
Yeah,
tip
the
of the wire?
curve. Yeah.
Alright.
Don't make too much bend.
Sure.
Okay, may Dr. Linda continue with the next slide? You don't have any questions?
Yeah, sure. Go ahead.
So this is after pre-bill, showing the easy delivery of long dynamic stand. Dr. Linda. Dr. Linda, please.
We can see
Dr. Linda will
here
explain.
the easy delivery of the long dynamic stand, and we can see after that we have for the second dynamic also so easy.
You see how easy the long dynamic stand tracks the vessel?
Yeah.
It's very long vessel.
Very good deliverability.
Okay, next. Yes. And this is of course after pre-deal, after validation and post-validation, another OCT examinations, so, and then optimization, further optimizations to get very good result. Of course, we follow the MLD max philosophy, and Dr. Linda will explain the OCT findings.
Next.
Next.
We can see here the dynamic stand is well opposed and well expanded. Now SD section. And OCT pullback recording were not continuous, strictly in 4 times normal.
It's very beautiful.
Next.
Yes. So this is the after implementation of 2 overlapping strands. Dynamic stand were well approached and well expanded. There is no recession.
We have very minimal overlap in stop frame image number 4. But all strands are well closed and well expanded. No edge section.
Awesome result.
Vessel is diffusely diseased from proximal to distal, if you could remember. Okay. Next. This is the LED. After, of course, after progressive dilatation, from proximal to distal, very diffuse disease. If you look at the subframe image number 2 and 3, very distal, you still see a disease process, but the vessel has a negative vessel remodeling. And then going up, you see dissection and a lot of calcification in the mid to proximal LED. I hope you can see that from the data from the. I'm sorry, I'm busy looking at the doctor. Okay.
Take a deep breath in.
Okay. And this is just to show. Well, distally we implant another TES because we don't have dynamics of that size and length.
And then there is a small
And then-
continue. Small delivery of the dynamic. Yes. There is 2 dynamic stand. We have jeep. Okay. Right.
Next.
child of the LAD.
Acceptable, right?
Really, really good, bro. Acceptable is not enough.
Oh, thank you. You're really very kind. Thank you.
Any comment from
Next.
Madam?
The next,
Just a question on YOCT.
Why OCT, bro? A question from
Yes.
Yeah.
Yes.
Dr. Bilal Patel.
Usually OCT is not advisable for CPO intervention. I repeat, not advisable, because in CPO intervention, quite often we use dissection. And with OCT, by doing a lot of, we need to do a lot of contrast injection. Sometimes we need to do forceful injection. If we do that, we will make the dissection even worse and propagate spirally downstream. So, IFUS is the best. However, in this particular case, I'm very sure that my wire is intimal. I'm very pretty sure even though there is some dissection, I don't induce too bad dissection. If you see on the OCT findings, I induce dissection, but very limited. Not extensive dissection or deep dissection. So I'm confident that I can use OCT. The main reason is that I want to show the result of dynamic stent implantation to all of you, because if I use OCT, the image quality, especially to show stent apposition and so on, and stent expansion, is definitely much superior as compared to IFUS. That's the reason. So we need to be very sure that our wire is intimal. I will let you know the trick to do it. First, we need to be sure that our wire is intimal. Intimal means inside the CPO body. Second, we need to get a good flow, as demonstrated by half-strength contrast injection. We don't need to go to deliver a lot of contrast agents. So do proper lesion preparation. Now, in the case of very long CTO like this, in order to get good visualizations, we normally do double injection. Double injection means through the usual port and through the flush port of the OCT catheter. So we can get good blood clearance from inside the vessel. That's the trick. Double contrast or extra injection. Okay. So in case we still cannot get good image, we can use guide extension catheter. And whereas the guide catheter inside the vessel, just proximal to the region of interest. Now, in our hospital, we use a special guide extension catheter with four side holes, 4 distal side holes. So this gas extraction catheter is very flexible, hydrophilic coated, and the internal diameter, even though of the same size with the other competitor, the internal diameter is bigger.
What is the name of
So with
catheter?
this, Expressman,
Oh,
it is available in different sizes. So with the same catheter, we can get better lumen, safe. It will dampen the pressure because we have 4 side holes, and we can get good contrast or saline or dextran injection distally. You can even the gas extraction catheter for a long period of time during your procedure. Again, that's the trick of using OCT in CTO intervention, during CTO intervention.
sorry, Prof. Do you concern about, while we are doing CTO, sometimes we may create a bad dissection or something like that, and then if you use OCT, then because you force contrast or something like that, or fluid, something like that, then you may create a worse dissection. Is there concern about that? You can hear me? You cannot hear us, Prof?
Yes. Okay, yes, I have.
Can you hear me?
Oh, yes, sir. I can hear you, Prof.
Got it. Okay. Yes.
Okay, I think while you're finishing the case, Prof, can we just
Yeah.
have a lecture from Prof Saito for about 10 minutes?
Yes.
Back to you.
Yeah. Yes, you can.
Okay, thank you.
Oh, lecture.
I am Shigeru Saito from Kamakura, Japan. I will present Dynamics Coronary Bioadapter System. This is my disclosure. Major adverse cardiac event is still high and increase year by year after contemporary drug-eluting stent implantation. This is the Resolute trial and right-sided answer test trial result. Dynamics bioadapter stent is characterized by presence of unique uncaging elements, and acute performance is similar to drug-eluting stent. The bioresorbable polymer coating is resolved within 6 months. Low-dose sirolimus is eluted over 3 months, and cobalt chromium stud is seen at 71 micron. Uncaged bioadapter allows for restoration of vessel action and movement. Even after the uncaging, lattice of 3 cobalt chromium strands in a helical pattern maintain longitudinal continuity even after uncaging. After uncaging, positive adaptive remodeling is restored. Uncaging of the device enables the vessel and the device area to increase, allowing the vessel to preserve lumen area and blood flow over time. Vessel pulsatility movement is also restored after uncaging. This is a stationary OCT case example. You can clearly see the pulsatility of the movement after uncaging. Uncaging restores bus motion after nitro injection. Uncaging allows the artery to dilate in response to nitro. Vessel dilate in response to the heart's need for more oxygen. However, stents cage the artery and do not allow the artery to dilate. The removal of the stented vessels, rigid caging can facilitate the return of the vessel bus motion. Bioadapter restores radial compliance and minimizes inflammation by uncaging. Green color shows a greater vessel compliance. Vessel rotational movement is restored after uncaging. Caging the vessel impacts the degree and direction of coronary artery rotation, which is contributing to decrease progression and failure, such as fracture leading to adverse event rates. Bioadapter restores vessel rotation and may reduce event rates. Bioadapter allows vessels to return towards baseline angulation. In the right panel, you can see the initial angle was 138 degrees, and the middle, immediately after post-PCI, the angle increased to 154. But at 12 months, the angle returned to normal 148 degrees. This is an evaluation of sirolimus eluting bioadapter as compared to a total rings eluting stent in de novo coronary arteries. This is a bioadapter RCT study. We randomized the patient into dynamics sirolimus bioadapter system and resolute onyx total rings drug-eluting stent implantation into 1-to-1. And we follow up the patient at 30 days, 6 months, 1 year, up to 5 years. And the primary endpoint of this trial is target lesion failure at 12 months. And of course, we have secondary endpoints, clinical endpoints, and also uniquely, we have imaging endpoints by using OCT and QCA and IVAS. For this trial, from Japan, 14 hospitals, we have involved 222 patients into 1-to-1 randomization, and also from European hospitals, 21 hospitals, we had 222 patients randomized into dynamics or resolute onyx. And from Japan, for 80 patients, we had IVAS plus QCA exam at baseline and 12 months follow-up. And also for 20 patients from Japan, we had IVAS plus OCT plus QCA at baseline at 12 months. And this is primary endpoint timing. So number 3, dynamics bioadapter RCT trial, we will have primary endpoint result early next year. This is the coronary intervention evolution. We started from POVA, however, the POVA had acute recoil and abrupt closure, and also high restenosis rate. And then we introduced the bare metal stent. However, still, the restenosis was a big problem. And then we introduced the drug-eluting stent. However, drug-eluting stent had delayed healing and high long-term MACE rate. And then bioresorbable scaffold was introduced, BRS. However, it brought unacceptable rate and very late scaffold thrombosis. Now we will have bioadapter system. This can restore positive adaptive remodeling and vessel functions and restore vessel dynamic compliance and designed to preserve future re-intervention. Ladies and gentlemen, I want to conclude this presentation. First, Dynamex bioadapter has demonstrated the ability to adapt to vessel physiology by positive adaptive remodeling and by restoration of vessel function and by restoration of geometric dynamics. Dynamex bioadapter has acute performance similar to best-in-class DES. This RCT trial will show the safety and efficacy of the Dynamex bioadapter system compared to a contemporary state-of-the-art drug editing stand. And the last study will demonstrate the bioadapter's ability to restore vascular functions such as versatility, vasomotion, and to restore positive adaptive remodeling. Thank you very much.
Coba jalankan yang sebelumnya.
Okay, Prof. We just heard the lecture from Prof. Saito, recorded lecture. So I just would ask the
Yes.
panel's member, is it any of you have experience of using the bioadapter?
Mundur lagi.
What about Alpha?
Ya, mundur. Malaysia.
Okay.
Mundur.
Itu.
Oke, sini.
All right. Okay, Prof. You are online now.